as you stated, high bleeding risk patients are common. We see them every day. They're elderly, they have prior stroke, or a patient who is on an oral anticoagulant, who's frail, who's female, who is had a prior bleeding episode or is anemic. These are all parts of the high bleeding risk patients. In fact, we have a ARC-HBR group that identifies these patients using major and minor criteria. We see them every day in PCI, and when we do, we have to take into account their ischemic and their bleeding risk and make important judgments about the antiplatelet regimens. Often in these patients, we will use clopidogrel instead of ticagrelor, and if we choose a potent agent, it would be for a short duration. Importantly, we will reduce the duration of therapy and sometimes even think about dropping aspirin as one of the novel strategies to reduce bleeding without increasing ischemic events. And I think the other thing is that what we do in our procedure for high bleeding risk patients is very important. We usually choose thin strut stents. We try to reduce the number of stents if we can use FFR or IFR or QFR guided PCI to make sure that we are stenting the lesions that need to be stented. And we also use intravascular imaging. And I think those are really, really important. As far as the antithrombotic regimens, I already discussed that we would use a short duration of dual antiplatelet therapies and sometimes even drop aspirin. Whenever you have a high bleeding risk patient, or even for all patients, we should use bleeding avoidance strategies. So from the get-go, we would use a radial approach. We would use heparin or bivalirudin. We would try to avoid the use of GP2B3A inhibitors in these patients. And we would be very careful about stent selection as well as their dual antiplatelet therapies. Most importantly, we would talk with them about the risk of bleeding, and that so that they can understand both the importance of ischemic and bleeding risks. They're both just as important. And so once we educate our patients, then we have a really good way forward in avoiding bleeding complications in these patients by using radial and going to a shortened duration of dual antiplatelet therapies, abbreviating DAPT, and working closely with our referring physicians to make sure that they also understand what the strategies are.